my goal here is to kind of give a brief overview, and I do this in clinic also, as well as when I talk. I think it's important for me to know the why. That's a little bit how I got to where I am. It's always about understanding why things are happening. And so it can take a little more time in my clinic visits. It can take some more time when I'm meeting with trainees, but I always like to know the why. And so I've kind of framed this talk in the context of the GI tract and in the context of scleroderma about the symptoms that affect the GI tract and why they happen. And I think that's how I like to frame things. So, and then also what I don't want to do is to spend a lot of time being the sage on the stage, going on, and then not having any time for questions, especially if I'm not addressing something that those in the audience might want to talk about. So I'd like to chat for a couple minutes, kind of going over the GI tract and scleroderma, and then at the end have plenty of time for anything that we might want to expand upon in a discussion format, or if I didn't address something entirely. So the GI tract is extraordinarily commonly affected in scleroderma, as over 90% of patients with scleroderma have some GI involvement. And then again, we're going to get to the why in that. And so the pathogenesis of GI injury in scleroderma is felt to be related to progressive smooth muscle atrophy and eventually smooth muscle fibrosis. And that's the key there. And so why is that important in the GI tract? Well, unfortunately, nearly the entire human GI tract is composed of smooth muscle. And so if smooth muscle is the organ or what is affected, then the entire GI tract is going to be at risk, from the lower part of the esophagus all the way to the anus. And so it's entirely composed of smooth muscle. And so when that smooth muscle, depending on the location in the GI tract, is impacted, then there's going to be symptoms related to whatever portion of the GI tract is most severely afflicted. So if there's injury or scarring, which is fibrosis of the smooth muscle of the GI tract, then the normal function is impaired. And then we get to what is the normal function of the GI tract musculature and why, when it's impaired, do you get symptoms and which symptoms occur. So the normal function of the GI tract musculature is multiple. It propels what we ingest along the GI tract for digestion and absorption. And so when there's alterations in the way that food is propelled in the GI tract, symptoms can arise. Then the job of the GI tract is to mix food with the secretions of the GI tract to better aid in digestion and absorption. So these are the enzymes, the acid, the liquid in the GI tract that facilitates absorption and the appropriate intake of calories. And then a little less commonly appreciated, the function of the muscle of the GI tract is to minimize stasis of food in the GI tract, as this can lead to bacterial overgrowth. And the way I kind of explain this is that, if you were to choose whether you wanted to drink water from a beautiful flowing mountain stream or from a fetid pond in a golf course, you'd obviously choose the mountain stream. And it's the same way with the GI tract. We minimize the way any kind of pathogenic or bacterial accumulation in the GI tract by making sure it's moving through the entire tract. And when the muscles of the intestines are scarred, then that propulsion of food in the GI tract is impaired. And again, this just highlights that. In the esophagus, we have the muscles of the esophagus that propel a food bolus. And whenever the contractions of that smooth muscle is impaired, then we can get symptoms. So the dysfunction of the GI musculature leads to these symptoms. Common GI symptoms in the GI tract in patients with scleroderma include difficulty swallowing, heartburn and regurgitation, abdominal pain, distension, bloating, and then constipation, diarrhea, and incontinence. And so I think it's easiest to take a tour through the GI tract and kind of explain when the muscles of different organs dysfunction, the symptoms that you get, as then that kind of highlights why in certain areas of the GI tract there might be the development of certain symptoms and not in others. And then again, because the entire GI tract is composed of smooth muscle, you can take a tour through the whole thing and understand why certain areas will lead to certain symptoms. So the esophagus is composed nearly entirely of smooth muscle. And when you get dysfunction in that smooth muscle, you can get symptoms. Anyone who recognizes this screen has likely been the unfortunate recipient of a manometry catheter probe, which is how we assess muscle function in the esophagus. And so we place a transnasal tube up the nose and down the esophagus into the stomach, and then we measure the pressures of the esophagus along a catheter. And this is a normal swallow, and I like whenever I can to kind of highlight visually why symptoms can be explained. And manometry of the esophagus lends itself very well to visual interpretation. And so I, teach my medical students, residents, and fellows all the time, and then we look at this picture and we discuss that the reddish colors are higher pressures, and this is a normal swallow. And so what you see here is a top to bottom increase in pressure as the esophagus propels a swallow down into the stomach. And then in scleroderma, we can visually see why there's an impairment of the muscle of the esophagus and how that might lead to symptoms. On the right, you see a swallow of someone with scleroderma, and you see a complete absence of normal muscle contraction as the esophagus musculature is scarred and therefore dysfunctional. And so the esophageal symptoms related to scleroderma are related to two main factors. As you saw on the previous slide, there's impaired motility where the esophageal muscle doesn't contract well enough to move food easily from the mouth to the stomach. And that's why eating things like solids that are much more dependent, solids like meats and breads, which are much more dependent on the esophageal musculature to propel into the stomach rather than liquids that can usually get by with gravity. And then the other muscle impairment in scleroderma that relates to symptoms is the smooth muscle, lower esophageal sphincter. When that is weakened, there's an impaired barrier to reflux of gastric contents and their acidity. And that acid reflux leads to symptoms of heartburn and regurgitation. And then acid can damage the esophagus, leading to narrowing that can worsen already present difficulty swallowing. The treatment of these symptoms is multiple. With difficulty swallowing, unfortunately, there's no good treatments for muscle dysfunction. And so we're left with kind of altering the diet and then importantly excluding stricture from acid reflux disease, which can be dilated during endoscopy, which is a potential treatment. And then we try and minimize the acid content that is in the esophagus, and so that's by treating acid reflux disease. Usually this involves medications like the PPIs or proton pump inhibitors that normalize the amount of acid in the esophagus. And then we also have lifestyle measures that have probably counseled many people in this room on, and we have some other more alternative medications that we use frequently. In the stomach, which is more rarely involved in scleroderma, the cardinal disorder that can occur when there's scarring of the smooth muscle of the esophagus is gastroparesis or stomach paralysis. Symptoms here usually involve feeling full easily, nausea, and vomiting. It's diagnosed with a number of different ways, but treatment is usually both dietary and medical. We use common medications that include domperidone, Reglan, and erythromycin. And then we also recommend smaller meals that are easier to empty and avoiding eating late. The small intestine, I move to a little more or expound upon a little more because it is frequently involved in scleroderma. And the small intestine is the majority of the GI tract. By length, it's the longest portion of the GI tract at about 21 feet compared to much less in the rest of the GI tract. And its main role is to mix food with digestive enzymes and then spread the food throughout the small intestine for absorption. And then in between, its role is to sweep the gut to empty the small intestine, and that prevents that overgrowth and stasis of food contents. And so we can look at this visually also. On the left, you see a typical pressure recordings in the small intestine of someone with scleroderma. And then in the middle are control. And what you see is basically an absence of significant pressure waves that move food contents through the small intestine. And when you get impaired mixing of food contents or ingested contents with appropriate enzymes and secretions, you get impaired absorption, which can have a litany of downstream effects, most importantly on nutrition, which is what Michelle will talk about. And then you get impaired sweeping, where you get stasis of contents that aren't swept through the gut into the colon, and that can predispose to bacterial overgrowth. And small intestinal bacterial overgrowth is the predominant cause of small intestinal symptoms in scleroderma. It's a frequent sequelae of this dysmotility, and you get stasis in the small intestine leading to bacterial overgrowth, fermentation of ingested carbohydrates, and then bloating and diarrhea, which are the cardinal symptoms. And this can then subsequently worsen malabsorption. We treat small intestinal bacterial overgrowth because we can't treat the muscle scarring in scleroderma. We need to treat the sequelae. So we treat the symptoms and the likely component of bacterial overgrowth, and we do so by using courses of antibiotics that may need to be repeated because, as I've just said, we can't treat the underlying scarring, so we treat the bacterial overgrowth that results. In the colon, injury to the smooth muscle can lead to inertia and constipation. And so we use many medications that are commonly used to treat constipation and those that are then a little less commonly used. So we start with things like laxatives and stimulants and then move on to promotility agents to, for example, our Linzess and Amitiza or linaclotide and lubiprostone. And then to kind of finish our brief tour of the GI tract, I do highlight that the last part of the colon can be affected in scleroderma also. And we maintain our continence because of the muscles of the last part of the colon and the anal sphincters. And unfortunately, our internal anal sphincter and our rectum are all made of smooth muscle and can be affected in scleroderma. So we have the rectum, which is the last part of the colon, that's a reservoir. And essentially that filling enables us to maintain continence and to have a fewer number of bowel movements during the day. And then we maintain our continence through two muscles right at the last part of the rectum, which are the two anal sphincters, the internal anal sphincter, which is made of smooth muscle, and then the external anal sphincter, which is made of skeletal muscle. And in scleroderma, because of fibrosis of these muscles, a frequent symptom is fecal incontinence. And normally our continence is maintained by three mechanisms. Rectal muscle, which stretches and distends to accommodate stool. And then the internal anal sphincter, which is, as I've said, smooth muscle, which is closed until it senses rectal distension. And then the external anal sphincter, which is skeletal muscle and under voluntary control. With scarring of the smooth muscle of the rectum, that leads to less stretch and distension, and thereby less capacity in the rectum. And that decreased capacity leads to earlier relaxation of the internal anal sphincter, and then weakness due to scarring of the internal anal sphincter also compromises continence. And therefore, frequently when there's these muscles affected in scleroderma, then all of continence is dependent on the external anal sphincter. And when that is weakened for a variety of different reasons, incontinence can result. And the treatment in these cases involves avoiding diarrhea, which is much harder to control than solid stool. And then when you have things like bacterial overgrowth, you have already a predisposition to diarrhea, and so a struggle there. And then by strengthening the other muscles that aid incontinence, specifically the external anal sphincter. And so what I've hoped is on a brief, and I find myself talking quickly, tour of the GI tract, that we've gotten an idea that the entire GI tract is made of smooth muscle, and dependent on what areas are affected with the scarring and fibrosis in scleroderma, that any of those organs can be affected and the symptoms vary. And the treatments obviously vary dependent on the area and the symptoms that are being experienced. And now what I'd like to do is then finish with that backdrop to be able to then kind of tailor our discussion to any specific questions that have arisen, or to delve further into what available treatments are, how I approach patients who have a different area of the GI tract affected. Yes?
Is there a correlation between overall disease activity in scleroderma and the sequelae we see in the GI tract? I mean, if we're getting sicker GI-wise, does that correlate to systemic involvement or progression of disease? And if so, is there a way to stop the scarring that's going on? Is there research into that?
So the question is does the severity of GI symptoms relate to progression of disease overall? And that's a great question, I don't think easily answered. I'd wonder if Dr. Fisher has anything to say, but invariably the severity of GI symptoms then correlates with fibrosis in the GI tract. So to answer the GI portion of that question, certainly the severity of symptoms correlate with fibrosis in the GI tract. Now, I don't know much about reversing the fibrosis of the GI tract. That is thought to be something that is not, at least we don't have anything that is able to do that in the GI treatment algorithm. So we're left with then dealing with the symptoms and trying to minimize those. All right.
So I think the simple answer is that there isn't a lot of correlation, and that some patients may have horrible gastrointestinal involvement and remarkably no other organ involvement, and they manifest with their gut, and we don't really understand why. But I think maybe the reassuring side is that as GI symptoms may become more prominent, one doesn't have to then assume that the rest of their disease is going to sort of follow suit. I think it can be frustrating because patients may really struggle with GI involvement, and yet, the rest of their disease seems to be fine. They look normal on the outside. So.
Yes. So the question is, what about dumping syndrome and the irritable bowel? So we think of those as kind of different conditions, and certainly the symptoms of dumping syndrome, which often occur, which are often systemic symptoms like fatigue, flushing, lightheadedness, and then the symptoms of GI tract involvement in scleroderma have a lot of overlap. And then irritable bowel syndrome is a term we give to symptoms that really don't have the scarring and fibrosis that we see in scleroderma. But the irritable bowel syndrome has symptoms that are common to both IBS, which is irritable bowel syndrome, and scleroderma. So things like diarrhea, bloating are common to IBS, but are also very common in scleroderma, but related to likely a different physiology. So in IBS, it's likely multifactorial. There might be a component of intestinal dysmotility, but in scleroderma, it's really the dysmotility that drives the symptoms. Yes?
What are the first symptoms to finding out if you have it too long? Or
Sure. Yeah. So what are the first symptoms of finding out if the GI tract is involved in scleroderma? It's a challenging question for two reasons. First, GI symptoms are really common in those without scleroderma. And the GI symptoms that might be involved are also common both in when the GI tract is not affected. So I showed the manometry. The manometry is really one of the major way that we look at esophageal involvement in scleroderma. But that said, not always necessary, because in scleroderma, especially when there is difficulty swallowing, if we can confirm that dysmotility in the esophagus, but unfortunately there's not any medications that really stimulate esophageal muscle function. And so we can make a clinical assumption that if someone has difficulty swallowing and there's no narrowing in the esophagus, that it's related to that muscle dysfunction. And so I don't always need the esophageal manometry to confirm that. And then otherwise in the rest of the GI tract, symptoms are variable. In someone with scleroderma who has bloating, for example, I think it's probably safe to assume that there's some level of small intestinal involvement. And so I'm usually pretty early on and willing to try a course of antibiotics, for example, to try and see if there's any component of bacterial overgrowth. Yes.
Is there any benefit to shortening the tract that things go down to help with the problem of getting food through?
So is there any benefit to shortening the GI tract? And so, yeah, this is perfect for two reasons. One, it's something that I would never have thought to address in my talk, which is why I wanted to shorten it and make sure that we had time for questions. And secondly, that's, I guess, intuitively a very reasonable thought. Unfortunately, our GI tracts are that long for a very good reason. It's really how we absorb all of the nutrition from our GI tract. And my job, especially when the small bowel is affected, is to try and minimize the barriers to nutrient absorption in scleroderma, which can be certainly a challenge. But then what I wouldn't want to do is then to take a shortcut, which might make things pass through more quickly, but to the detriment of nutrition. Yeah.
So I understand that you have fermentation, disorganization, but you also have to use the tract. If you see more of those areas, does that mean there's more also in the tract?
Yeah, and I didn't get into that portion of the GI tract involvements, but we know that there are certain vascular malformations that are more common in the GI tract in patients with scleroderma. And I have to say, I'm very comfortable saying when I don't know. So I don't know of a correlation between peripheral or skin telangiectasias and vascular kind of lesions and those in the GI tract. And then the important concept also is those lesions in the GI tract are not always symptomatic or do not always lead to bleeding as a sequelae. Bleeding is why we worry about those lesions, but many people have lesions that don't bleed. And so it's really if there is a significance or we think there's a possibility of a significant bleeding or source of anemia that we would be concerned. But I don't know about a skin-gut correlation. Yes?
Do you feel spasm a part of the sequelae?
So actually, no. Esophageal spasm is a different condition, but is also then almost like too strong a contraction of the esophagus, and we see quite the opposite in scleroderma. That said, the symptoms of esophageal spasm and those that can be associated with things like refluxes can overlap quite a bit. Yes?
Is the use of probiotics more of that, or do you encourage that?
Yeah, that is something that I wondered would come up. So probiotics have a lot of it's of intuitive benefit. One of the things I like saying in clinic, and someone's probably heard me say this, is that none of the GI tract is sterile. I don't have a sterile lifestyle, or profession. But the thought is that with probiotics, you maintain the normal, healthy bacterial population in the small intestine and the colon specifically. And so they're thought to be more related to colonic diseases and in diseases like IBS, where we think there might be alterations in normal bacteria of the gut. Unfortunately, there's not a lot of data supporting our use of probiotics one way or another. And then in scleroderma, we frequently use antibiotics to kind of prevent bacterial overgrowth. And there's no data suggesting that probiotics worsen bacterial overgrowth. And it's certainly not, it's intuitive to say that after a course of antibiotics, I want to make sure that the right bacteria then regrow. But in essence, what I summarize this by saying is that there's no good recommendations one way or the other. They're unlikely to hurt, certainly. There's maybe a possibility that they help, but I, as a policy, don't feel strongly one way or the other. Yes?
With a couple of antibiotics I recently had for other reasons, the warnings were that they could cause staph infections if you could overly ignore them. So that was one question. And then on commercial, there's a lot of PPI products that have been attacked from being controlled.
Yeah, so it's great. I think one of the things we need to balance is the benefits and then the risks of any medication that we choose. And certainly antibiotics and PPIs are no different. Regarding the antibiotics, I don't know much about staph infections. We don't see staph infections in the GI tract, and so it's not something that I usually deal with. There we go. So C. difficile is a different infection that causes a diarrhea and a colitis. And there certainly are antibiotics that can predispose to C. diff infections, which can be a terrible infection. Luckily, a lot of the antibiotics we use for bacterial overgrowth in the small intestine are ones that are either used to treat C. diff or are very low risk for causing C. diff. Not always the case, certainly, but overall. And then with PPIs, I think it's a struggle. Certainly, there was the impression that they were safe and we could use them, put them in the water. But we're starting to realize that that's not the case, and it shouldn't be a surprise because it changes normal physiology. With PPIs, they've been associated, and that's a big difference from causing, right? They've been associated with chronic kidney disease, dementia, heart attacks. And the thing to keep in mind there is that risk overall is extraordinarily small for any one individual. And because we know that acid reflux disease is a condition that's extraordinarily common in scleroderma and recurs if we don't treat it, then we're forced to weigh that benefit against the potential likely very small risks, although real, especially at a population level. Yes?
I wanted to go back to this mechanism of the incontinence.
Sure.
The external and the internal.
Yeah. Perfect.
You're saying the external failure is not just a smooth muscle. Is it, by the time it gets there, it's just not strong enough to control it because it's that lack of involuntary control, even by feedback that's so frustrating?
Yeah. And I think I really did want to deal with incontinence when I talked because it's probably the most challenging symptom to discuss. And I think to answer the question, which was, I forgot to repeat it, if the external anal sphincter is voluntary or made of skeletal muscle, kind of why then the predisposition or frustration with incontinence? I might be paraphrasing, I didn't get it quite close. And so the answer is twofold. One, it's like any check mechanism. If you then, in a normal state, we have three kind of facilitators of continence. And then you're only depending on one, you're going to have more of a range of error no matter what you do. And the two big ones then are, and I can't discount the problem with the impaired rectal distension. So the rectum normally is a compliant or structure that stretches to accommodate a volume of stool that we can then hold. And then so with rectal scarring and fibrosis, you have less distension and there are less capacity. And then that means there's a loss of a brake on continence. Because when that rectum senses stretch, that internal anal sphincter then, under nobody's control, relaxes. And then if that's happening more and more frequently, you're having more and more workload on that one voluntary barrier to incontinence. And then if you combine that with liquid or stool or diarrhea, that continence becomes much more challenging to maintain. Yes?
Excuse me. What do you recommend doing for Barrett's esophagus to keep it from getting too cancer?
Barrett's esophagus. So what do I recommend doing for Barrett's esophagus? So as a backtrack, Barrett's esophagus is a precancerous condition of the esophagus that's associated with reflux disease. And so Barrett's esophagus can occur in anyone with reflux disease. I think the thing to keep in mind is that Barrett's esophagus itself, while it is a risk factor for the development of esophageal cancer, overall the risk of any one person with Barrett's esophagus developing esophageal cancer is very low. We estimate it at 0.1 to 0.5% per year, so under 1%. That said, anyone with Barrett's esophagus, we get biopsies that should be looked at by multiple pathologists to make sure there's not worrisome features of more precancer or dysplasia. And then we basically recommend surveillance protocols. So we biopsy regularly to make sure that there's not features that are concerning for the development of cancer. And currently those recommendations wouldn't be changed in someone who has a predisposition to reflux disease like scleroderma, and just would be once every 3 to 5 years. Yes?
I have scleroderma of the gut. I live in a remote area of Wyoming. I had 18 blockages 18-inch tubes. It was horrible.
I imagine.
I moved to Fort Collins, Colorado, found excellent care, and on the 19th of January of this year, the surgical team walked in and said, "We know you don't want surgery, but you don't have a choice." My large intestine, which had not given any problem, had elongated, twisted, and tied itself in a knot. They went in and they took out the first half of the large intestine, the ileocecal valve, and part of the small intestine. That is 278 days ago. I'm on a very low fiber diet. No dairy, no fiber. And I'm doing really well. Now, up in the remote area of Wyoming, they kept throwing fiber at me. And you see it on the TV. You see it all advertising. Eat fiber. And that was exactly what I could not have. What's your comment about this fiber?
I ignore everything I see on TV. I'm kidding. It is a good point. So I think the big question is given small intestinal involvement with scleroderma, what do you do about the recommendations for high fiber diets? And it should be noted that certainly fiber in the normal small intestine is healthy. It can promote good bacteria formation. We don't even fully understand the benefits of fiber. That said, in a small intestine where there's a known dysmotility, fiber can precipitate a lot of symptoms. It's poorly digested, and so we think it maintains colon health quite well when it's normally propelled into the colon. But when it isn't, in cases of small intestinal dysmotility, it can do a couple of things. One, it's very prone to fermentation, and so it can worsen with bacterial overgrowth. It can worsen abdominal distension, then distension of the small intestine, which can then very much look like intestinal blockages, both from a symptom and even on an imaging standpoint, like on CAT scans. And I had recently a patient who was scleroderma and with small intestinal dilation, who was taken for surgery despite there being no blockage. It was just dilation of the small intestine. And so it's really taking it in context. And then understanding that the benefits of fiber might not be in all cases. So we have a couple more questions, yes? And we have a couple more minutes.
When I was having a lot of gastro issues 2.5 years ago, and I put a picture in for TPN. I also had yeast overgrowth colonizing in my esophagus.
Mm-hmm.
Was that just a random thing, or is that relative?
Sure. So the question is, I think, one, an issue, and then two, a question. You had a central line placed for IV nutrition or TPN, and then also had yeast in the esophagus, right? And so the easiest is to deal with the yeast question. Anytime there's stasis, you can get for example, we talked about in the small bowel, you can get overgrowth. We don't see a lot of yeast infection in the small intestine and the colon because acid in the stomach is, even with PPIs, is usually sufficient to get rid of any yeast. In the esophagus, though, it can be there, and anytime you have stasis of contents or contents that aren't moving, you can get a candidal or yeast infection in the esophagus. So it's common in any condition where there's dysmodal esophagus, not just scleroderma. And then I think the question about IV nutrition is not unimportant and probably a great segue to Michelle's talk, but it can be necessary sometimes if small intestinal scarring is so severe that we can't really overcome the impaired absorption of calories and nutrients. We'll finish up with one, yeah.
Do you have a diagnostic schedule of sorts that you would sort of let go? When the PFTs every so often, the echoes every so often, do you have a schedule
Yeah, not as much for a couple reasons. The diagnostics that I have really confirm what is already likely to be occurring in scleroderma. So I'm certainly happy to read esophageal manometries till the cows come home, but I really don't need to put people through it to know that the esophagus is likely desmodal. And then the what to do with those diagnostics if I did those at a regular basis is really unclear. And so rather my role in scleroderma, and I've talked about this, with my rheumatology colleagues, is essentially to try and maximize symptom control in a GI tract that's impacted by scleroderma. And really the diagnostics that I might do really don't impact that attempt to gain symptom control. Certainly if there's a confusion of symptoms or there's a concern that I might be missing a contaminant or alternative etiology, that's where diagnostics come in. But something like the regular PFTs or echoes isn't something we really do.